Hello.
Hello, Alonzo. He's not here with us?
Nah,
Nah.
something about dinner with his wife or something.
Oh,
I don't know.
okay. Priorities. Okay, well, why don't we begin then if we ever discuss this? So, this is a story of a 21-year-old with no significant past medical history coming in with 1 week's worth of abdominal pain and fullness.
Is it a male or
So,
female? And is she pregnant?
Male. Yeah, 21-year-old male.
Okay,
Yeah.
probably not pregnancy.
Close but no cigar.
Yeah.
So a little bit more about the presenting concern. So in pretty much usual state of health up until past week or two, where he started noticing diffuse abdominal pain present both before eating and after eating, not necessarily worsened with food, and has noted early satiety, fatigue, and also some weight loss.
So this is absolutely perfect for Dhruv since he's going into med peds, because I can't figure out if there's a medicine case or a peds case. And so it doesn't matter to Dhruv.
Yeah, and actually I was wondering if he had any sort of, if he had any sort of pediatric history, but it looks like not.
Nope.
Probably like relatively healthy kid prior to getting all this. Yeah, apparently the VA decided to join. Abdominal pain, fullness in a 21-year-old. I mean, right now I'm sort of thinking more the bad stuff, like malignancy, probably lymphoma in this guy if it were presenting like this. I don't see an infection. I don't have an infection in my thought process that could present like this without anything, without a fever or anything like that. Autoimmune, IBD maybe, but I would probably be seeing more diarrhea rather than like early satiety. Could be an endocrine thing. Could be that this patient's in DKA, but again, being on the endocrine service, I've seen at least a decent amount of it. But otherwise, yeah, that's where I'm starting right now.
Okay, so I'm going to give you some tips here. I would pick one of these features and try to think why a 21-year-old would have these features, and instead of just guessing some random things.
Mm-hmm.
And so I'll do that after we let FB go and see how he addresses this. And I'm sure that he's going to name 16 cancers that could do this.
I'm not going to name cancers. I'm going to name a few weird diagnoses that I want to add to the list just because we're listing diagnoses. Like, always keep in mind these ultra rare diagnoses, because if you don't think about them, you will never diagnose them. Abdominal epilepsy, FMF, porphyria, acute glaucoma. All of these can cause abdominal pain, and you have to really think about them, and it takes a long period of time to diagnose them. So I want to comment a little bit on the fullness. The fullness is kind of maybe the rabbit hole here. What is fullness? It's probably just either a feeling of satiety, early satiety, or there's something occupying the abdomen and making it more distended. Is it gas or is it fluid? And this is very important, especially on the physical exam and on imaging, because our differentials are really different. If this is gas, are we having problems with our transit? Is the patient having stools, or he has obstipation? And if this fullness feels like it's edema, then why is the patient has why does the patient have weight loss? The tempo of the illness seems subacute unless you are going to tell me that this fatigue and weight loss have been ongoing for months and precede this problem. So I don't know if this is a culmination of something that reached a certain tipping point that's pushing the patient to seek medical attention. But in terms of mechanisms of disease, I think malignancy is up there, and we, in a 21-year-old, we think of metastatic testicular cancer mainly in terms of solid organs, or we think of lymphoma, leukemia, which can do anything, invade any organs. It can invade the liver and the spleen and cause ascites. And these are the main cancers I would think of in a 21-year-old, although you can have a lot of other potential issues. Non-malignant etiologies, I would think of subacute to chronic infections, and we're talking mainly about mycobacteria that can also wreak havoc, cause a lot of issues, invade the organs, and cause dysfunction of the liver. I also think of chronic inflammation due to infection mimickers such as sarcoidosis, probably. He's not the most common type of person that this would happen in, but it's also a possibility. These are my initial thoughts.
So y'all gave me a lot to work with. I was trying to think more anatomically. And so early satiety, the question is he having difficulty emptying his stomach? And so you could certainly get an ulcer. You don't always have pain with an ulcer. You could just get some obstruction, but he doesn't have any nausea and vomiting. Then with diffuse abdominal pain, that could be anywhere in the abdomen. And so I would worry about liver diseases. And once I start worrying about liver diseases, I start worrying about things like the mono syndromes, even though he doesn't have a fever or sore throat, but you don't always get that with infectious mono, because sometimes it just causes liver disease. Could this be some kind of hepatitis and he's not yet complaining or have not yet noticed any problems with jaundice until we actually examine him? The fatigue and weight loss make me think about those liver things. Every now and then you'll see a 21-year-old with gallstones, and gallstones might present like this. Somebody in the chat said the magic words: abdominal pain at 21-year-old, you better not miss Crohn's disease. Crohn's can do almost anything. Mm-hmm. And that could also have these symptoms. There are things that are missing for everything we've mentioned. Mm-hmm. And so we're going to need a lot more information. So it's really hard to narrow this one down. What you didn't tell us, and so I always go back to Cope's early diagnosis of the acute abdomen, is does anything relieve the pain? Does it wake him up from sleep? You didn't mention anything about diarrhea or constipation, didn't mention anything about nausea and vomiting, so wanted to be sure about those things. And you didn't specifically say there's no fever, although you didn't mention there was a fever. And certainly better, it's actually hot shower. Well, yeah, warm hot showers, Travis. Could he just be smoking a lot of dope?
So I'll give you some more information. If you really push him on when these symptoms started, he says that he may have had intermittent abdominal pain for the past month, but that really wasn't bothersome. But he was having fatigue over the past month and early satiety. All these kind of constitutional symptoms culminated along with severe abdominal pain in the past week. But with this, he has had no associated fevers, no change in bowel habits, mild nausea, but no emesis, no dysuria, no emesis, no hematochezia, no melena.
How much weight loss?
So looking at the chart, he had a pretty recent PCP visit. He's lost about 20 pounds.
And why did a 21-year-old have a PCP visit recently?
21-year-old set up a PCP visit because he had just been feeling tired. And they had checked his blood counts and said that, well, there's no anemia, and checked a thyroid TSH, and that was normal. And he was going to have follow-up, but he didn't make it to the follow-up before presenting to Katie.
So that's sort of interesting. So this is like 2 months of fatigue
Yeah, at least a month, maybe if you push him farther than that. Yeah.
with presumably a normal CBC.
Mhm.
Now, just because this is unremarkable labs, this and some people have gone there. This could be progression of chronic kidney disease. That could certainly do this. So it could be that he has something like glomerulonephritis, and it's been brewing, and now we're going to find an elevated BUN and creatinine. Had they, by any chance, did they check chemistries at the previous visit?
They did check chemistries at the previous visit, and those were also remarkable.
They were remarkable.
Unremarkable.
Unremarkable. Okay. Do you want to go to labs next, or do you want to go to exam next?
That's up to you. I think the standard approach, I would say, let's go to exam.
Okay, let's examine it.
So his temperature on exam in the emergency room is 36.4. He's mildly tachycardic to 101. His blood pressure is 150/95. Respiratory rate is 16. He's in no distress, satting well on room air.
Stop right there, Dhruv.
Why in the world does he have a blood pressure of 150/95? As soon as I see that, I'm thinking either he is in severe pain or there is something wrong with his kidneys.
Right.
That's everyone's ER blood pressure. I promise you.
Yeah, if I saw Travis, I'd probably have that blood pressure too.
So my tip is recheck it.
Hey,
Recheck it.
I'm sorry.
No, it's always high. I feel like people walk into the ER, they sit down, the triage nurse takes their blood pressure. It's high, they log it in, and then you go see them. They've been sitting there for 5 minutes. If it's high, just recheck it. That's my tip for all my students. If it's high, recheck it, both arms.
Yeah,
His
but
recheck,
the pulse is also 101.
his recheck vitals were about the same.
150/95 for a 21-year-old. I mean, I understand if I came into the ER at my age, I'd expect it to go up, but 21-year-old, that's really, and with no previous medical history other than this fatigue.
Mm-hmm.
Does he use drugs?
No history of IV drug use. Does not smoke. Does not drink.
Okay. And does he have any other behavioral concerns?
No. He's he finished high school. He's working if I remember correctly, he was working in the service industry of some sort.
Is he celibate?
That I can't remember. Not pertinent to the.
Not pertinent to this case. Okay, so let's go. So what are we looking for here, FB, on the physical exam?
Mainly any sign any signs of organ insufficiency. If we have liver problems, we are looking for signs of chronic liver failure, or even acute liver failure. So jaundice, any pallor from anemia. We're trying to look for any change in mental status. If there's any palpable mass in the abdomen, and try to percuss the abdomen to try to see if there's any fluid or air in there. Try to palpate the spleen. It's a hem-onc bias. I mean, it's hard to palpate it unless it's like 25 centimeters. And Travis wants to focus it, which is the new standard, I guess. And I want to see if he has edema in his legs. It would be unusual and to have a weight loss that high with edema, because edema is meant to increase the weight.
Somebody's on call and getting. Yeah, and would you add lymphadenopathy?
Yeah, sure.
Okay, so what do we have, Mohit?
Yep. So in general, he's in mild distress secondary to pain. He appears pretty well nourished. EV exam, he is mildly tachycardic, similar to his vitals. No murmurs, rubs, or gallops. No JVD. Palm exam, he is cleared auscultation bilaterally. Abdominal exam, he is soft and non-tender to palpation, except for the right upper quadrant, where you also notice some hepatomegaly.
So, just because my first chairman of medicine and my chairman of medicine for the entire 18 years I was at MCV was a hepatologist. This is always interesting, is how do you decide someone has had hepatomegaly? And I was taught differently than we discussed last week. I was taught to percuss the liver or scratch the liver to get a size rather than just seeing how far it is below the costal margin. So just for, that's an interesting controversy. How did you decide that there was hepatomegaly?
So I felt like a firm liver, like I can't remember the exact, I don't think I wrote it down on the exam.
Okay.
But well below the costophrenic angle, you could really palpate kind of throughout, all the way going into like the midline.
Yeah, but if he has alpha-1 antitrypsin and has emphysema from that and liver disease, that'll push the liver down. I'm being. I got beat up about this when I was an intern, and I have post-traumatic stress disorder over this.
It's a good point. It honestly, it just felt abnormal.
Yeah. Okay.
Neurologically, he was intact. Extremities, he had no edema. He had good pulses throughout. And then GU exam, he actually had a left varicocele.
Left varicocele.
Does that help you, Dhruv?
I'm trying to remember on which side, if you get a varicocele, it indicates that there's compression of the vein and possible tumor.
He's too young for RCC.
You think
He's too
so?
young for renal cell carcinoma. I've seen a 28-year-old, but I mean, he's too young.
Not even like a syndromic RCC?
I'm not sure.
It can do anything. We know that can do anything. That doesn't explain. That usually does not explain hepatomegaly.
Mm-hmm.
So the hepatomegaly makes it sound like I was worried about the liver, so now I'm still worried about the liver. I guess we better get some labs.
Yeah, I think we should.
What do you want to give us?
So let's start with the CBC.
Okay.
CBC is notable for white count 3.9, hemoglobin 13.4, platelets 273, had a normal diff.
What race?
African American.
Why did I ask?
Not sure.
Disease bordering on leukopenia.
Yeah, and on average, just on average, blacks have lower white counts than whites. And so that could be totally normal for him. Whereas if Dhruv came in, we might start thinking that maybe that's a low white count. And so you have to make an adjustment. And the way I learned this, and this, I like to tell anecdotes, but back in the day before CTs and ultrasounds, when someone came into the ER with abdominal pain and you're trying to decide whether they need an appendectomy, you had to have 2 out of 3 of fever, elevated white count, and pain in the proper place. And using that screen, more blacks were missed than whites because they were less likely to have a white count over 10,000 because they started out lower. And I was taught that, and that is definitely something that you need to be aware of, that you have to look at the white count differently, at least consider that possibility. Is there anything that, Fernand, have you, anybody ever tell you that when you're on benign hematology?
What specifically? I'm sorry.
That on average, people of African descent have lower white counts than other
Yes.
people.
Yes.
So that we can't, if it's with a normal diff, 3.9 doesn't bother me because of race. So that's probably worth knowing. Sometime in your career, that's going to help you.
So the CMP showed sodium 138, potassium 4.7, chloride 99, bicarb 29. BUN 10, creatinine 0.96. Glucose 88. Calcium was 10. ALP was 290. AST 85, ALT 100. His INR was 1.3. His PT was 13.8 and his PTT was 33. His albumin, I believe, was within normal range. I didn't jot it down.
This is interesting.
And then I can wait to give the UA, or I can give it now.
What do you think, Dhruv? Do you want to go over this first?
Billy, the bilirubin, for people asking, all those I didn't jot down because they were within normal range.
So, Dhruv, what do you want to do with this?
I mean, I'm not really seeing much of anything at the moment. I'd go ahead and get a UA.
Okay, well, I think we have some stuff going on with the liver, so I want to discuss the liver first, especially since we think we have hepatomegaly.
Mm-hmm.
I have some ideas, but FB, what are you thinking?
So I would translate these labs into layman's term as there is something inside the liver that's infiltrating it because of the predominant cholestatic pattern that's partially affecting the synthetic function because our INR is prolonged, and that's causing mild hypercalcemia, which is a kind of a sign that there's something going on. And we all know that hypercalcemia can occur if something's producing PTHRP or something's producing.
Is that hypercalcemia? It's not hypercalcemia where I am.
Actually, where's the albumin? Normal. Oh, so it's not hypercalcemia. It's just like leaning towards the upper limit of normal. So I'm wrong on this. The differentials are really broad, and I go back to the mechanisms. I still think there could be a malignancy, and in most cases in a young guy with a cholestatic pattern and weight loss, it could be lymphoma, sometimes isolated to the liver, Hodgkin's or non-Hodgkin's, sometimes outside of the liver. This could also be amyloid, but I expect a more progressive pattern, and some other organs being affected in general. So some diarrhea, some maybe the early satiety patient has been having was due to gastroparesis. I don't know. So a UA would be really helpful because it would, if it shows necrotic range proteinuria or some glomerular proteinuria above 1 to 2 grams per day, then this might give us a sign that this is a possibility. Obviously, imaging can be helpful. The third thing I would think about invading the liver and causing pattern like this is sarcoidosis. And in general, it's hard to have sarcoidosis in the liver without anything, at least radiographic, in the lungs. So that could be a sign if the X-ray shows hilar lymphadenopathies or parenchymal disease. It can also cause hypercalcemia, which we do not have here. I would not rule out subacute to chronic infections also lying in the liver. We have to think of brucellosis if this guy is coming from an endemic area, or TB if because he has the wasting syndrome and if he had the right exposure, or atypical mycobacteria. These are the main things I have on my mind.
Yeah. So when I look at these liver tests, he has some inflammation and he has obstruction. And I don't know whether the obstruction is leading to the inflammation or the inflammation is leading to the obstruction. It's the fact that his bilirubin's not too high suggests that it's probably, and this is not perfect, it's probably within the liver, not in the biliary tract, because usually you'll get hyperbilirubinemia. So why would a 21-year-old have this? Well, we have no history of ulcerative colitis, and this is a little young for primary sclerosing and cholangitis. It'd be very unusual for him to present this way if he had primary biliary cirrhosis. It's mostly women, mostly in their 50s, so we'll get rid of that one. He's not an alcoholic, and these are not alcoholic numbers. Could he have been exposed to some kind of toxin? That would be a possibility. He's not on any medication, so it's not a medication side effect. I'm intrigued about the possibility of a variety of viruses. You know, I mentioned mono-like syndromes before, and I think mono-like syndrome could cause a lot of what we're seeing here right now. And so I'd be, I'd be checking for all the hepatitis and all the viral infections while I'm doing everything else. The INR being 13 point, the PT being 13.8 with an INR of 1.3 may or may not really tell me anything. It's not really perfect. And so that really doesn't get me to where I'm going. I guess it could be alpha-1 antitrypsin. Then there's just numerous things. I mean, the case we had, I guess it was last week, that we don't have a sexual history, and he told us sexual history is not important. So this is probably not syphilis. HIV, we always check HIV in every 21-year-old, but I don't think he's going to have that. I'm trying to figure out how the urinalysis is going to help us. Perhaps Fernand was smarter than me and has already figured this out. So let's see what the UA shows.
Yeah, sure. So the acute hepatitis panel was negative.
That included EBV and CMV?
It did not, no, but at least the hepatitis.
Just the alphabetical hepatitis.
But this is where I think this will be fun discussion. So the UA, I'm going to go through the whole thing.
Okay.
So it's cloudy urine. Specific gravity is 1.026. pH is 6. 2. Negative glucose, negative ketones, 2 plus bili, 3 plus blood, 4 plus urobili, negative nitrites, 1 plus leukosterase. Whites are 11 to 20. RBC is greater than 50. 2 plus bacteria, and then the ultimate culture was negative.
What's the protein?
The protein was 2 plus.
Okay. So this becomes even more fascinating. I wanted to blame it on the kidneys before, but I thought that the BUN and creatinine would be much higher. Now,
Right, yeah.
0.9 might be significantly elevated. How large is this guy? You didn't give us a BMI.
He, I think normal weight is about 200. His BMI is 25, and he had gone down to 180.
Yeah, so you wonder in a 21-year-old, does he normally run a creatinine of 0.6, and 0.9 is actually significantly elevated. But this is your big chance, Dhruv. tell us everything we need to know about this urinalysis, and then I'll see if I can add anything.
All right. So cloudy. So just going through it, cloudy urine with 2+ bacteria with a negative culture could just be that he didn't have a clean catch. Spec grab of 1.026, possibly explained by the fact that he has early satiety and probably not that great appetite, so he's probably not getting a lot of take in. Doesn't have glucose or ketones. The 2+ Billy is interesting. I don't necessarily have a great differential for bilirubin in the urine. The 3+ blood with greater than 50 RBCs and 2+ protein makes me think that this, if the creatinine indicates that this guy has kidney disease, that it would be a glomerulonephritic picture. But again, I'm confused about the bilirubin in the urine, and I don't know why.
Well, it could be from whatever's going on in the liver that he's excreting the urine and he's excreting. It's not that much bilirubin, but enough to get into the urine.
Mm-hmm.
Okay. Well, at this point, what's the next thing you want to do? And then I'll tell you what I want to do.
I mean,
I have about 3 things I want to do.
probably right upper quadrant ultrasound, liver biopsy, and a kidney biopsy.
No, not yet. Not yet. We'll see what our hemonc fellow thinks.
So I just wanted to know, do we have AKI or we don't know?
We don't know.
No, it's-
What was his creatinine 2 months ago?
Creatinine 2 months ago was like 0.8.
0.8. Okay, so this, I mean, let's say this active sediment is an acute problem. It really does not point directly at the etiology of the at least it's not clear cut at the etiology of the kidney insult, but it's an active sediment with some blood in it. Proteinuria, it's really hard to quantify. A 2+ could be glomerular or acute interstitial nephritis, or any injury like to the tubule, to the urinary tract, that's non-specific. I really cannot decide based on this UA if there's anything. I mean, we were saying that it's not compromising kidney function. At least this is my understanding. But it seems like there is inflammation in the kidney. Is it affecting the tubule or is it affecting the glomeruli? The one thing I want to do is spot a protein to creatinine ratio to try to quantify the proteinuria. If it's very high, mainly above 2 to 3 grams a day, I'm leaning towards glomerulonephritis, and then my workup is really directed towards that way, and I need a biopsy. If it's lower, I mean, 1.5 to 2 is very borderline, could be AIN or glomerulonephritis. It's hard to know if I have one of these weird non-AIN, non-GN kidney injuries, because you can also have it with a microvascular problem. Some small vessel vasculitides can cause some blood in the urine without causing significant proteinuria. So I mean, protein to creatinine ratio is something I want to do. I want to take a look at the kidneys with an ultrasound to see if they're small, they're big, they're infiltrated by something, because whatever is infiltrating the liver could be infiltrating the kidneys, and this is a sign that there's an inflammation in the kidney. I go back to to lymphoma here. I can add amyloidosis, but in general, it's a bland glomerulonephritis that causes a massive nephrotic syndrome, which I'm not getting the impression here, which is not the impression that I'm getting. So I'm still nervous about lymphoma invading the kidney invading the liver, unless it's an infection that's subacute to chronic, that's also invading both and causing non-specific inflammation in the kidney.
So I'm going to go in a slightly different way here. So first of all, very concentrated urine. So he's probably not taking in very much fluid. It's interesting that his BUN to creatinine ratio looks like it's perfectly normal. Perhaps he's not eating very much and he really would have a low BUN if he wasn't volume contracted. And maybe that explains his slightly high bicarbonate. The next thing is that he has 3+ blood and greater than 50 red cells. They don't mention casts, and therefore we need warm urine. We need a nephrologist, a microscope, and warm urine to see whether or not he has pure red cells or red cell casts. If he has pure red cells and we're concerned about glomerulonephritis still, then we're going to have to think about IgA nephropathy. That'd be the one that might present with pure red cells. Pure red cells, even in a 21-year-old, we have to think about some kind of urinary cancers causing the red cells. So we're going to have to think urologically also about this. The 2+ protein, given that this is a concentrated urine, I'm going to predict is not going to be incredibly high when we either get an albumin, urine albumin creatinine ratio or urine protein creatinine ratio. I would do that because that would obviously give us more information. But 2+ protein is not surprising with that degree of concentration of the urine. So I want warm urine under a microscope. I want either protein or albumin creatinine ratio, and I agree an ultrasound of the kidneys. And then think about, are we looking for a cancer or are we looking for a glomerulonephritis? Any questions about that from anyone? Does that make sense? Yes, TB can cause hematuria. Okay. What can you give us, Mohit?
Yeah, so I can't give you a lot of the stuff that we were all kind of pontificating on because those weren't done. What we went straight to was CT imaging of the chest, abdomen, and pelvis. So
why? Because they can. Why do they get a CT? Because they can.
Because we want to find that incidentaloma.
So
yes.
Hail the donut of truth.
And there's a small thing in the adrenal gland, and we don't know what the hell to do.
So
that's my worry for this month, since I'm on endocrine consult.
So CT chest showed bilateral pulmonary nodules, bilateral hilar lymphadenopathy, mediastinal lymphadenopathy.
We can just stop right there, Dhruv. It's got to be one of two things. One of
either Hodgkin or sarcoid.
Yeah, and maybe histo, because of where he lives.
Oh, right, yeah.
Okay.
I would think that those are far and away the top three just from that chest CT. Mm-hmm. And we probably could have gotten there with a chest X-ray without having to do a CT.
CT abdomen and pelvis shows a 12 by 9 centimeter necrotic exophytic left renal mass. With tumor extension into the left renal vein and IVC. Greater than 50 hypoattenuating liver lesions.
Oh, nuts.
And plenty of retroperitoneal lymphadenopathy.
As an intern, I had a patient come in who had sudden onset of ascites and really profound edema, and a right-sided heart murmur. And this is back in the days of 2D echo. This is like 1975, before we had 3D echo. They did an echo, and we could see the tumor growing up through the right atrium to the right ventricle, and diagnosed renal cell cancer, because renal cell cancer will definitely go in to the vena cava and grow up. It's that, either that or hepatocellular carcinoma. And I said, those red cells, we had to figure out if those red cells glomerulonephritis or are they urological, and so we had to consider urological stuff. Fernand, do you think that this is going to be renal cell when they biopsy it?
So initially, even if you stop the sentence at he has a big renal mass and we see the findings in the chest, I would say this could all be non-Hodgkin's lymphoma. But then you tell me that he has invasion of the renal vein and the IVC. There's not a lot of things that can cause this. It's probably gonna be an RCC. And Dhruv was initially drawn by this left varicocele finding, which I believe Mohit mentioned because it's valuable. When do you mention varicocele in a random case? It's gonna be it's gonna be one of those RCCs. I'm surprised the patient doesn't have bone lesions because it's pretty common when this is metastatic. And it's fairly common to go metastasize to the liver, to go metastasize to the lung, and to lymph nodes, and to the spine. I'm leaning towards RCC.
Yeah, I'm leaning the same way. And given that this guy is so very young, I'm leaning toward it actually being like a syndromic RCC. So, I mean, I'd be looking for things like, does he have maybe paragangliomas or like a pheo or again, one of the weird like syndromic cancer, like genetic cancer syndromes.
This could also be a sarcomatoid RCC, which are pretty aggressive and that can like really progress despite therapy.
Mm-hmm.
So, Fernand, am I right that the two cancers most likely to extend into the venous system are HCC and RCC?
Yes.
And so you have to bet on one of those, and there's no good reason for him to have HCC. So we're sort of, if we have to put our money down, we have to put it down on RCC. So Mohit, teach us.
Yeah, so he ultimately, with all these findings, quickly got worked up and expedited workup with oncology on board, got biopsy of the liver, and was found to have clear cell renal cell carcinoma.
Yeah.
Was discharged from the hospital and has been getting ipilimumab and nivolumab for therapy. Something that I didn't really add into the story because I wanted our emphasis to be on kind of our urine analysis and all that, but he actually also simultaneously got diagnosed with HIV. So he had
nuts.
a birth count of 169, viral load of 24,000, was started on Biktarvy, and now follows with ID as well.
That's why he probably has early onset RCC, I think.
Yeah.
Oh, is there an association there, Fernand?
I do believe that you have an increased risk of early solid cancer with RCC. I may be wrong, but I can look this up.
Yeah, and Mohit lies to us and says there's no sexual history that would help us.
So no, there wasn't. There was actually, he has tattoos, and the thought is that one of his tattoos.
Okay.
Well, you didn't mention that in the physical exam.
No, because I didn't want to get sidetracked.
That's really sad, and it's particularly
tattoos
sad.
would have given it away.
One of my really good golf buddies is at MD Anderson right now getting treatment for RCC. Fortunately, he's had some early response, and I think the treatment is much better. Maybe just for a couple of minutes, you could talk about advances in treatment in RCC, Fernand.
Yeah, and actually, Fernand, another thing, if you know about it, I didn't know a whole lot about it, but reading the onc progress notes, it looks like he had an FH germline mutation consistent with the hereditary leiomyomatosis and renal cell carcinoma. syndrome.
I knew it.
So
He
Drew
would have had one of those
You're
syndromic cancers if it was this young.
So RCC, I memean, it's fairly chemo resistant. So when it's advanced, we don't treat it with chemo. We mainly rely on TKIs or anti-angiogenesis medication, and it's very immunogenic. So we treat it with our new immunotherapy agents. The new tendency is to treat with the backbone of immunotherapy plus an anti-angiogenesis medication. We can also do the combination of ipilimumab and nivolumab, which are two complementary immunotherapy agents. The combination is very toxic, up to 30% grade 3, 4 side effects, and you can shut off or down any of your glands or serious organs by an autoimmune phenomenon. When the responses are there, I mean, the control is fairly decent. You can achieve long-term control. Cure when you're metastatic is more difficult than melanoma, where we're talking about it more and more because some people are out of the woods more than 5 years after starting treatment. I can't remember the follow-up, but there are some people who can live 3 years with adequate control of their metastatic disease. And when you're more localized, the curative treatment is surgery mainly. We used to do a lot of radical nephrectomies, but now with the advances in surgery, we can do more localized surgeries, and I would say partial nephrectomies if possible, to try to preserve your kidneys, because once you have a kidney that's gone, you already have CKD because you have less than 50% of your nephrons left. And it's important to preserve your capital of nephrons. It has a tendency to invade the renal veins and the IVC and can cause swelling in the legs. If it invades the left renal vein, can cause left varicocele. How do you differentiate it from a regular varicocele, which commonly happens in young men? It's mainly when it's not when you cannot when the person is standing up. When the person is standing up, you can see the varicocele, but when they lay on their back, generally it should go back in. But if it's not reintroducible and the varicocele doesn't disappear, then this is worrying for a fixed obstruction, and especially if it's on the left side and it's recently acquired. So this is when you can, I mean, there are anecdotes that this has been diagnosed with varicocele. I'm not sure how common this is. A lot of times you can have flank pain, some blood. They will think that you have stones. That's why we do a CT scan to look at the urologic tract whenever we have hematuria. It can cause a lot of anemia and sometimes polycythemia. So whenever you have a polycythemia, especially if your erythropoietin is high, if nothing is showing up there and you have some hematuria, look at the kidneys there. This might be the area where you're producing your EPO and you're developing the polycythemia.
So that's really great. Mohit, thank you so much for a case that made us think so hard. Dhruv, your take-home points.
And just to go off, because I think Fernand asked about like the propensity for early renal cell carcinoma in patients with HIV. There's an article in the Lancet from 2007 that suggested that it might be on the order of about 0.8 to 2 increase in relative risk. But otherwise, yeah, no, this was a fascinating case. And I guess I like the whole fake out of we're going to be talking a lot about the urine studies when at least the clinical picture that I got seemed to look a lot more like malignancy, and really that's what it ended up being.
Sean, what's your big take home?
Yeah, I think the thing that this drives home is for hematuria, like this needs to be worked up every time and separating into big buckets of glomerular and kind of more solid things. and just how important imaging and perhaps getting urology involved if your imaging is negative. So just don't ignore hematuria. If you see it, make sure that it's worked up appropriately.
It's interesting. I did a morning report last week at UAB, and it was a patient who presented with hematuria, and they spun things down and did not find any casts, and it ended up being IgA nephropathy, which is why I mentioned the IgA nephropathy. I sort of knew that, but it reminded me of that. But it really boils down to, if you just have pure red cells and you're trying to blame it on the kidney alone, it's going to be IgA nephropathy. Otherwise, you got to look for all these tumors. And I think I'm glad that you mentioned that, Sean, because I think that's really the most important thing for us to remember, is you can't ignore hematuria, especially when you can show that that there's nothing going for glomerulonephritis. So I think it'd be interesting. I think we would have gotten there with the ultrasound, because I think we would have seen the mass with the ultrasound, and then we would have gotten the CT scan. But Mohit, thank you so much for presenting this case, because I think there are so many great lessons. Fernand, I'm going to give you the last words, because we have the pleasure of having a Hem/Onc fellow to give us the last words in this case.
Oh, thank you for the case. Thank you, Mohit. Say hi to St. Louis. I don't miss it though. So
But they have great Italian food there.
we have everything in New York. It's fine. So yeah, I think I got stumped initially when I told Dhruv that he's too young for that. I mean, cancer always amazes me. Never say never. Even if somebody's young, whenever somebody has an unusual tumor when they're young, think of something syndromic or hereditary. And it's sometimes important to know about these syndromes and try to identify them, because it may affect the rest of the family. And it's no joke. As Sean said, I think it's important to chase any hematuria. And I can imagine this guy, sometimes if you see your PCP, you're 21. I mean, I can tell you right now, when you go on the patient side, sometimes you're not taken seriously, and some of my doctors sometimes are not taking me seriously with my shoulder pain. So I can understand if somebody young going there like can be dragged for months before he has a clear diagnosis and he's brushed off. So whenever you have, I think, red flags, weight loss, and the patient who's 21 saying I'm not feeling right, I think it's important to try to identify the problem, and we may save these patients because we might localize their cancer at an earlier stage than metastatic. And unfortunately, I feel that women who are young in their 20s tend to have their breast cancer diagnosed at a later stage. Same for this guy who's metastatic. I'm not sure if we can avoid this metastatic diagnosis, but I think it's really important not to take lightly any subjective complaint from any patient, and this is something I've learned along the way, because it's better to be safe than sorry.
Well, I think that a lot was learned tonight, and thanks everyone for coming. We're going to brag about this one when it comes out on Twitter.
Yeah, and I just want to say thanks to one of the interns at WashU, Janki Luther. She's the one who gave me this case. She wasn't available to present today, but this is all her doing. So
great. Y'all have a great evening.
Okay. Bye now.